Assalamu alaikum. Welcome to Journal Club of this week. I present a case report titled Vital Root Resection with Regenerative Retrograde Vital Bulb Therapy done by American Group and published in 2025. Vital root resection initially was introduced by Haskell in 1969, and it offers an innovative approach to conserving teeth. This technique allowed for the retention of the tooth's vitality, although the outcome varied when calcium hydroxide and amalgam were used to seal the exposed bulb. Conceptually, regenerative retrograde vital bulb therapy using bioactive scaffolds and bioceramic materials on the exposed bulb of resected root can promote the healing of mechanically injured bulb and maintain its vitality. There have been no reports of attempting to preserve tooth function and vitality using retrograde vital bulb therapy with a bioactive scaffold and bioceramic material in the root resection of a vital tooth. Therefore, this case report aimed to present the outcomes of root resection of periodontally involved fractured mesobuccal root in a maxillary first molar with retrograde vital bulb therapy. A 56-year-old female patient presented to the postgraduate clinics with a chief complaint of swelling and pain in her upper right quadrant. The patient took antibiotics for 1 week, which alleviated the symptoms, and the patient reported no significant medical history and no allergies. Intraoral examination revealed localized gingival swelling on the buccal aspect of tooth number 3. The tooth was vital, responsive normally to cold and EBT, negative to percussion but positive to palpation. A deep isolated periodontal pocket with pus drainage was detected at the mesobuccal root, associated with the lack of keratinized gingiva and chirotype 3 gingival recession. Radiographic and clinical findings showed angular bone loss and Glickman class 1 furcation involvement, with Guttaberka tracing indicating a periodontal origin. Between tooth 3 and 4, tooth number 3 was diagnosed with a normal bulb and acute periodontal abscess with suspicion of mesobuccal root fracture. The treatment plan included exploratory surgery with a vital mesobuccal root resection, regenerative vital bulb therapy, and guided tissue regeneration. The exploratory surgery was performed using vertical and papilla-based incisions, followed by elevation of a full-thickness flap to access the infrabony defect. The lesion was debrided and vertical fracture lines were confirmed in the mesobuccal root of tooth number 3, which was subsequently resected. Necrotic pulp tissue was found in the mesobuccal root and was removed, and root end preparation was performed until bleeding was achieved. A dehydrated amnion chorion membrane, ACM, was placed as a bioactive scaffold, followed by placement of biodentin to seal the remaining canal space. Periodontal regeneration was supported using ACM and collagen dressing within the bony defect, and post-operative radiographs were obtained, and patient was prescribed antibiotics for 1 week. The post-operative follow-up showed progressive healing and maintained bulb vitality of tooth number 3. An early visit demonstrated mild flap swelling without infection, and the tooth remained responsive to cold testing. By 2 months, soft tissue healing was evident with the probing depth reduced to 2 mm and absence of symptoms. At 4 to 6 months, everything was within normal limit. However, at 9 months, gingival recession was developed on the distobuccal root, and at 1 year, the recession was progressive, and the tooth was stable had stable bone levels and no radiolucency, and this led to planning of periodontal soft tissue root coverage surgery for which the patient consented. At the 1 month follow-up after the root coverage surgery, the site was stable. At the 2 month follow-up, plaque and calculus were observed, and cleaning was done for the patient with the oral hygiene instructions, and the probing depth around the distobuccal root were equal or less than 3 mm. At 18-month follow-up, tooth number 3 remained functional, asymptomatic, and vital, responding normally to cold testing after vital mesobuccal root resection, and the clinical evaluation showed improved soft tissue phenotype, increased keratinized tissue width, and stable probing depth of 3 to 4 mm. And previously noted gingival recession improved following root coverage surgery, and radiographs demonstrated stable alveolar bone levels with normal hard tissue healing at the resection site. In conclusion, this case report demonstrated that vital root resection combined with regenerative vital pulp therapy can successfully maintain pulp vitality and function in maxillary molar. The biologically based approach preserves coronal tooth structure, supports pulp healing, and may serve as a less invasive and more cost-effective alternative to conventional root resection with root canal treatment and full coverage restoration. However, randomized controlled trials are needed to validate indications, define success criteria, and confirm long-term outcome.